Welcome to this series where I'll be reviewing the 2025 AACE Consensus Statement on the algorithm for the management of adults with dyslipidemia. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces you can actually remember. Let's begin. Today we're talking about low LDL, defined as less than 40 milligrams per deciliter. When you see an LDL that low, pause and ask why. First, consider the secondary causes: lipid-lowering therapy, malnutrition, cachexia, malabsorption, chronic liver disease, chronic pancreatitis, cystic fibrosis, and end-stage renal disease. If none of these fit, it's time to think about monogenic hyperlipidemias. The key genes to remember are MTTP, APOB, PCSK9, ANGPTL3, and SAR1B. Each of these plays a distinct role in lipid handling, and each is associated with a specific disorder. MTTP mutations cause A-beta lipoproteinemia. APOB mutations cause familial hypo-beta lipoproteinemia. PCSK9 loss-of-function mutations cause familial hypo-beta lipoproteinemia, the mild form. ANGPTL3 mutations cause familial combined hypolipidemia. And SAR1B mutations cause chylomicron retention syndrome. Despite their differences, all of these disorders share one core feature: defective synthesis, assembly, or secretion of ApoB-containing lipoproteins. Let's start with A-beta lipoproteinemia. The problem here is with the MTTP gene. It encodes the microsomal triglyceride transfer protein, which is essential for attaching triglycerides during lipoprotein assembly. These patients have severe fat malabsorption, fat-soluble vitamin deficiencies, acanthocytosis on peripheral smear, spinocerebellar ataxia, peripheral neuropathy, and retinal degeneration. Now let's move to familial hypo-beta lipoproteinemia caused by mutations in the ApoB gene. In the homozygous form, both alleles are affected, resulting in marked reduced or absent ApoB lipoproteins. The phenotype mirrors A-beta lipoproteinemia, though it's often less severe. In the heterozygous form, which is much more common, LDL levels are below the 5th percentile, and many individuals are clinically asymptomatic. But there's one critical complication to remember: hepatic steatosis. Because ApoB is required for VLDL assembly and secretion, reduced ApoB availability impairs hepatic triglyceride export, leading to hepatic lipid accumulation and steatosis. So when you see a patient with very low LDL and normal triglycerides, particularly in the absence of lipid-lowering therapy, your next step is clear: perform a liver ultrasound. Now let's talk briefly about the chylomicron retention syndrome, which is associated with SAR1B mutations. In this disorder, the enterocytes can assemble chylomicrons normally, but they cannot secrete them. The vesicular transport of chylomicrons into the lymphatic system fails. That leads to intestinal lipid trapping, severe malabsorption, steatorrhea, and fat-soluble vitamin deficiency, especially vitamin E. Unlike A-beta lipoproteinemia, ApoB is present, but stuck inside the enterocytes. It's a secretion defect, not an assembly defect. PCSK9 and ANGPTL3 deserve a brief mention. PCSK9 loss-of-function variants lead to increased LDL receptor recycling, so more LDL is cleared from the circulation. These patients have low LDL levels but no pathology. In fact, it's cardioprotective. ANGPTL3 loss-of-function results in familial combined hypolipidemia, characterized by low LDL, low HDL, and low triglycerides. Because ANGPTL3 normally inhibits lipoprotein lipase, its loss accelerates lipid clearance across all pathways. So to summarize, MTTP mutation, A-beta lipoproteinemia, absent APOB lipoproteins, defective assembly, fat malabsorption, soluble vitamin deficiency, neuropathy. Gene APOB, APOB mutation, familial hypobeta-lipoproteinemia, truncated ApoB, impaired VLDL secretion, we get hepatic steatosis, PCSK9 loss of function mutation, mild familial hypobeta-lipoproteinemia, increased LDL receptor activity, benign cardioprotective, ANGPTL3 loss of function, familial combined hypolipidemia, accelerated lipolysis via lipoprotein lipase, asymptomatic, and SAR1B leads to the chylomicrons retention syndrome. We have impaired chylomicron secretion, steatorrhea, fat-soluble vitamin deficiency, and growth failure. To make this easier to remember, I've organized everything into a clean reference table. Just sign up for the newsletter and I'll send you the link straight to your inbox. Remember, the key is to distinguish assembly defects, secretion defects, and clearance variants. That framework makes these genetic lipid disorders effortless to recall. This was another bite-sized episode of Endo in a Bite. If a detail went by too quickly, do not worry. I've prepared notes for you. Visit www.easyendoprep.com to sign up for the newsletter and have all the key pearls delivered straight to your inbox. You can also explore the full board review course there for deeper learning and ABIM exam preparation. Remember, stay consistent, and together we'll work through the AACE consensus statement on the algorithm for management of dyslipidemia, one bite at a time.